Hi everyone, it's Robin. I have decided to go ahead and record the Periop Nursing PowerPoint just because there is a lot of information to this, and in hindsight, I don't want you to miss out on some of the particulars of this information. So even though I did kind of go individually through some of the slides during class, this is actually the content for the entire PowerPoint for the Periop Nursing. Not the post-op, because we already did that. So this is just the periop, okay? All right, I'm not going to go through the objectives. You guys can read through those. Let's go ahead and get started. So in surgical nursing, there are three areas: pre-op, intra-op, and PACU. Pre-op is, of course, when you're getting the patient ready. That is the admission area. Intra-op is during the procedure, during anything that they're having done in the OR or the procedure room. And then PACU is the recovery area, and that includes phase 1 and phase 2, and we'll go through each of these steps. So step 1, pre-op patient interview. It's really important that we're getting the best, absolute, most complete health history that we could possibly think of to get this patient ready for the OR. We don't want to find out, we don't want any surprises when they're in the OR. So if you can kind of think through, if you were the surgeon, what would you want to know? So let's kind of go through this. So pre-op patient interview, you are getting a full and total health history. That includes allergies, any previous surgeries, if they've had any issues with anesthesia in the past, if they have any family members that have had issues with anesthesia. We are making sure that they have completed any labs if the surgeons have asked for labs to be completed prior to them having the surgery. This is the time to find this out. We don't want to find out just as anesthesia is walking into the room, preparing to take them down the hallway into the OR, and find out that the patient did not get any pre-labs done. So it's really important as the admitting nurse, the pre-op nurse, that you are making sure that the patient has fulfilled any orders that the surgeon has asked them to have. We're also going to be assessing the patient's emotional state. Are they ready? Do they really know what they're having, what procedure they're having? And are they okay with it? This is just a very, very general overview. Once again, as nurses, we're always assessing, and at this point, we're assessing, hey, is this patient ready to have this procedure? And that is a lot of subtle clues, and as nurses, we're really good at picking up on those subtle clues. Depending on the facility that you're at, the patient may be marking the particular site that will be involved in the surgery. Sometimes we'll just have them write a yes on a particular leg or an arm or a finger, something like that. Sometimes the surgeons will do it, but that's all facility preference. We're also going to be finding out if the patient has any metal anywhere. Why? Because a lot of times, as we know, if you have an MRI, you cannot go and have an MRI. But we also want to know about metal for a particular reason, and we'll kind of talk about that here in just a little bit in terms of the OR. But it is a fire hazard, and I'll explain what the difference is between one or the other. We're also going to be making sure about consents. We're going to have an anesthesia consent as well as a surgical consent. One thing that you might want to make sure of, in terms of making sure that the patient has had those pre-lab orders, obviously the risk of bleeding increases as the INR rises. So oftentimes surgeons will have patients get that INR checked 1 to 2 days before surgery. Typically, if the INR is greater than 1.5, they may receive a low dose of vitamin K to kind of normalize that INR. But either way, it is up to the surgeon's preference, okay? Okay, pre-op, psychosocial. As I said, we're making sure that the patient is ready for the procedure. There is a lot of unknown here, especially if it involves very private parts, if I may say that, very private parts of the patient whether it's breasts or those kinds of things. They might have concerns with their body image. There may be some past experiences that have affected how they are managing their feelings at that moment. They may have some sort of knowledge deficit, not really knowing what to expect before or after. And it all really depends on what kind of surgery they're having. Is it elective? Is it urgent? Is it cosmetic? Is it diagnostic? All of those things affect how the patient can be feeling at the time. And then, of course, we always have the age-old question of, will I wake up during the seizure, during the surgery? And I think that that's a pretty common fear, and one that anesthesiologists hear all the time, and they are really, really good at answering those kinds of questions. So obviously, as nurses, we're always trying to do our best, but don't feel like we have to answer all the questions. We can kind of say, hey, when anesthesia comes in, they'll go over all the medications with you. And that in itself is very, very soothing to the patient. I think I went over this particular slide in class. That is really important as the pre-op nurse to determine what medications the patients are taking. And we went over that. We went over recreational drug use, some herbs and supplements, those kinds of things. Of course, with those herbal meds and vitamins, they can increase bleeding, depending on which one. So they generally will have patients stop 2 to 3 weeks before surgery. And then, of course, we want to know if they're taking any antiplatelet medications, if they've been on any NSAIDs or steroids, antibiotics, those kinds of things. And we've already talked about the INR. So just know that we need to make sure we're getting a full list, okay? If you're not familiar with the patient's medication, make sure that you're asking what the medication is. It's okay to ask that. We kind of just went over this just a moment ago. What kind of medications are you concerned about? You're concerned about herbal meds and vitamins because they can increase bleeding. Surgeons generally have patients stop 2 to 3 weeks before the surgery. Also, if a patient is taking warfarin at home, the prescriber may order a bridging of enoxaparin injections preoperatively as an anti-thrombotic therapy before the surgery, okay? And bridging, what it does is it provides that continuity of therapy, therefore decreasing the risk of thrombosis. So if someone is on warfarin, we need to make sure that the surgeon, if the surgeon had them go to a bridging, a therapeutic bridging medication, such as enoxaparin, that the patient did so, okay? Hopefully that makes sense to you. I think it does. Pre-op health history questions. Okay, this is a whole multitude of things, but we are trying to find out everything about this patient prior to them going into surgery. So we're going to be asking about allergies, psychosocial history. Do they have any respiratory issues, cardiac issues, renal, endocrine, hepatic, muscular, integumentary, neurological, GI, immune, whether they have fluid and electrolyte imbalance history, whether they've had nutritional problems. All of those things are really, really important. We will in particular go over OSA here in just a little bit, but I do mention it just so that you do realize that that is part of the health history. And, you know, each surgery does have its own worries and its own concerns, but we really try to minimize any complications if at all possible. I will make sure I point this out right now. Why are we concerned about metal? And that goes back to a couple screens ago. Let's go back here. Why are we concerned about metal? Well, depending on where it is, it can heat up. So metal that is well secured to the bone, such as a hip or a knee joint replacement, will not be affected by an MRI. The metal won't heat up, and it will not move in response to the MRI machine. But if the metal is near an organ, such as, let's say, the prostate, something like that, they will not be able to have an MRI. Okay. Also, one thing, it is recommended that patients refrain from wearing any powder or perfumes or deodorant or lotions prior to any procedure, because some of them can have metal in them. I'm not sure if you all knew that or not. Okay. Let me go back to the screen we were on. Okay, so I think we're back on there and we've gone through that. What are some surgical risk factors? I'm just going to go ahead and list them. I would be surprised if you don't already know them. I know that you know them, but let's go ahead and list them. Age, smoking, nutrition, obesity, obstructive sleep apnea, so OSA, if they are immunocompromised, or if they have any fluid and electrolyte imbalance. Because surgery is just like trauma. It breaks, protein breaks down, and those patients that are already having an imbalance, they're more at risk for developing hyperglycemia, especially if the surgery takes longer than they thought. Okay, so just want you to be aware of that. The obese patient. Unfortunately, this is becoming more and more common, as we all know, not only with pediatric patients, but with the geriatric population as well. If they are obese, more than likely they have multiple comorbidities, and the more comorbidities really does equate to the worry that there could be more complications. Okay, it really does require a team approach in terms of making sure that everyone on the team is aware of those comorbidities and has made a plan in case if any of those comorbidities should equate to a complication during the procedure. We do ask patients that do have OSA, so obstructive sleep apnea, typically those are the obese patients, whether they have a CPAP or not. And we ask them to bring that with them, because in the post-op area, more than likely we will have them wear that CPAP, because that will be how we will ensure that their airway stays open and that they maintain good oxygenation. Let's talk about the geriatric population. Okay, what is their ability to adapt to stress? Okay, I believe you know the answer to that. They have a decreased ability to adapt to stress. And what about their sensory abilities? They have more sensory deficits than you might think. Okay, than you might even just come to mind, right? They may have problems with vision. Their hearing might be impaired. Their sense of smell. So in the geriatric population, their sensory is decreased, okay? They also have additional fears. I mean, let's face it, they've been living much longer on this planet, and they have more history. Sometimes you'll find a geriatric patient that has no surgical history whatsoever, and that's a wonderful thing to a certain extent. They don't have the experience, they don't have either a positive or negative experience to surgery. They don't know what to expect. But then on the other hand, you could have a geriatric patient that has been in a surgical area multiple times, has had multiple procedures, and has all kinds of fears that we can only even imagine. And what we're trying to do is just minimize that. Okay? We've gone over this a couple of times in class. Geriatric patients do have a poor clearance of anesthetic agents, and they do have a delayed arousal. So those are things you're really going to be watching out for, especially if you are in PACU, right? Because that is when they will be waking up. They also have other issues that are definitely more definitive with their population. They have more pulmonary issues. Sometimes they're more at risk for DVTs just because of lack of ambulation or decreased ambulation. They have an increased wound dehiscence because more often than not, they have protein, nutritional values. They have nutritional imbalances, so maybe they have less protein. They're at increased risk for wound infection and delayed healing for just a multitude of other reasons. Okay. Culturally, we went over this particularly in class in terms of pain. We talked about pain and how different cultures and age groups verbalize their pain. So as a pre-op nurse, it's up to you to really try to maybe understand what they're going through. And if you're a Christian, and they are as well, it's totally okay to pray with them. I have prayed with my patients multiple times. What kinds of spiritual needs they have. Do they have special beliefs and practices? Is it okay to receive blood products? That is one of the forms that is passed out during the pre-admission phase. And as a nurse, you are going through that as well. Let's talk about some cultural considerations. In some Asian cultures, there is a tendency to avoid talking about pain. And, all the different ethnicities and cultural, their small villages, wherever the case may be, we don't know what is appropriate for them. And it is okay to ask. Okay, that's what we're here for. And that's what our surgeons and our PACU nurses want us to find out about in pre-op. Okay, so let's move on to legal. Okay, this is a biggie, one thing that I did not go in class, did not review in class, and I want to make sure that we go over here. So let's talk about informed consent. Basically, informed consent by definition is a shared decision-making process between the healthcare provider, which is HCP, and the client, so the patient. And it has to be in the presence of a witness, and then the surgeon also obtains a consent. So what are the 4 conditions that must be met for a consent to be valid? Well, they have to know that the patient has to know the details of the procedure or the treatment, and of course that is written out for them in just typed out on a form. Number 2, the patient needs to know the risk and the benefits, including the potential harm, serious injury, or possible death. Number 3, the patient needs to know if there are any alternative procedures or treatments available. And number 4, the patient needs to be aware of any potential consequences of refusing procedure or treatment. Oftentimes, the consequence is they can continue to be in pain, or there will be no change in their health condition. Sometimes it's just as simple as that. But the patient does need to be aware of what could happen if they refuse this procedure, a procedure or treatment. And of course, the surgeon must address all the patient questions prior to entering the OR. That's not something that's part of the 4 conditions, but the surgeon really, it's up to him to make sure that the patient is aware of all of those parameters that we just went over. I have a really kind of scary situation that I'll mention to you. I was in PACU, and I had a patient that had given informed consent to have a particular procedure done to one of their lower extremities. And during the actual procedure, while the patient was in the OR, this patient happened to be a chronic smoker. And when anesthesia tried to intubate this patient, the patient kept bronchospasming, and it continued for multiple times. Well, long story, the anesthesiologist said, you know something? This procedure, the disadvantages of the procedure, the consequences of the procedure outweigh the benefits of this. So I am choosing not to continue with this procedure. So they stopped doing everything that they were doing in the OR. It was in PACU. The patient woke up. The surgeon was there, anesthesia was there, and they explained exactly what happened while they were in the OR, why they had to stop the procedure. because the patient kept having these bronchospasms, and it was up to the anesthesiologist to make the final call to cancel the procedure in midstream. Well, of course, the patient was very upset, and just she was beside herself. And the surgeon said, "Well, this is what happened. Let's see if we can come up with another alternative." Well, the surgeon and the patient came up with an alternative, and the surgeon had the consent. And as the PACU nurse, I was going over it with him, and I said, "Wait a minute." I said, "This patient cannot sign this consent, and because they've had sedation." And he said, "Well, I'm pretty much doing the same thing that she consented to before." Well, in actuality, he had not. And as a PACU nurse, and any nurse really, it's our job to advocate for our patients. At that point, he insisted that the patient would be able to have this procedure because the patient had corrected the consent form. And at that point, I went to my boss, and eventually we ended up finding the family, and the family made the consent with the patient, and the patient was scheduled to have the revised procedure. I want to say it was about 6 or 7 hours later. Long story, as nurses, it is our job to advocate for our patients and make sure that everything is done the way that we feel that it should be done and according to the law. Okay, let's move on to the next one. That was a long story, but one I hope that you will understand. Pre-op, the biggest thing here is that as student nurses, you cannot witness any form. Okay, you can be there, but you cannot be the legal witness. So we always want to make sure that you have a nurse with you, and that we are advocating. We're making sure that all the required forms are signed and in the patient's chart. But the important fact is, as a student nurse, you cannot be the legal witness for any form, consent or otherwise. Pre-op teaching, we're always making sure that we're doing thorough teaching to ensure that we're reducing complications and improving patient outcomes. Okay, we're also including family and any support. We're supplying them with any instructions. All the research points to discharge teaching. It is most effective in the pre-op setting. Okay, so a lot of surgery centers, a lot of hospitals have gone to all the discharge teaching being completed in the pre-op area. And it's very, very good because patients are, they're awake, of course, they haven't had sedation, and family is there and they can be present and everyone can ask questions. Okay, so as your pre-op nurse, you're the pre-op nurse, is your patient ready? Well, you think you've done everything, and then all of a sudden, all these things start flooding in your head, and the surgeon asks you, "Well, are they ready?" And then all of a sudden you realize, "Oh my gosh, I forgot to do this," or "I forgot to do that." Unfortunately, as the pre-op nurse, unfortunately, as the pre-op nurse, it is your responsibility to make sure that you and your team have that patient ready when the surgeon says, "Okay, let's go." Some of those things that you need to make sure that are taking place, have you asked if the patient has been NPO? Okay, what is their NPO status? Obviously, you're not going to be having a surgical procedure if they have had anything to eat or drink. Depending on the facility, clear liquids, there can be some sort of change with that. So make sure you know what the policy is with clear liquids, when patients can have their last clear liquids. Have you placed the IV? Do you have fluids running? Do any pre-medications need to be given? We're doing a lot of the multimodal now for pain control, and surgeons are giving gabapentin and acetaminophen prior to the procedures. So those are pre-meds. Do we have any pre-antibiotics hung? Do they need to be started? Research says that as long as not as long, but research proves that if the antibiotics are given, I believe it's 30 minutes before the first cut or before the first incision, it markedly decreases the chances of infection. Are the patient bands on? Do we have a current H&P? Okay. Is the site marked? Has anesthesia reviewed everything? Are all the consent signs? Those are all on the pre-op nursing team. This is just a fun picture I have. Just kind of, you can look through here. It's the pre-op checklist the day of the surgery. Okay. Now we're moving on to intra-op. This is the time where the patient is actually in the OR where the procedure is taking place. And by the way, there's a lot of questions in terms of whether it's general anesthesia or local, and we'll briefly go through that as well. Okay, I just sort of modified my screen because I just realized that some of the words you might not be able to see. So, intraoperatively, okay, if you've never had the opportunity to be in the OR, it is an amazing thing to visualize how sterility is managed, okay? This is something that you do not need to be, you're not going to be quizzed on this. You're not going to be tested on sterility principles because that is the job of the OR tech and the OR nurse. However, it's important to understand that sterile staff can only touch sterile articles, okay? Tables are sterile at the table level only. Gowns are considered sterile only from the waist up, okay? Those are just some important facts that you will notice when you're in the OR if you have a chance to be in there. As I said, let's talk about anesthesia. There's 4 types. You have general, regional, sedation, which can be monitored anesthesia care, which is considered a MAC, and then a local. Don't need to know the specific kinds, but I think it's kind of interesting just to be aware of them. So let's talk about general anesthesia. What classifies general? Well, they're intubated. Okay, that's all you need to be aware of. Regional anesthetics. Okay, that is when somebody is having some sort of typically it's pain management for surgery that numbs a particular part of the body, maybe from the waist down. Okay, 2 of the most frequently used are spinal anesthesia and epidural anesthesia. If you're a female and you've had a child, typically you will know what epidural is. Spinal and epidural blocks really just involve blocking the sensation from the legs or the abdomen, and they inject local anesthetic medication in or near the spinal canal. Okay, a lot of details there, but just if you're curious, that's what regional is. Local really depends on the surgery, the site, the patient, or the surgeon preference. You can see they're kind of going into the foot. A lot of times they'll do spinal and a local. They'll do combinations. It really depends on anesthesia and the surgeon itself. Okay, intra-op care. So basically, once again, we're still in the OR, okay? These are things that the nurses are checking on before the surgery takes place. Is the room prepped? Is the patient in the particular position that they need to be in? Do we know what we're going to be doing with the body parts, okay? Or anything that is coming out of the patient. Maybe there's a device that they're having removed. And the patient, I don't know, maybe they want to keep it. Or maybe it's a pediatric patient that really wants to see his adenoids because everybody said they're so big, okay? You want to know what they're doing with the body parts. We also are making sure that we're preparing the surgical site. And most importantly, we are making sure that a timeout takes place. Timeout confirms who the patient is, their date of birth, surgical site, the surgeon. Has the site been marked? Okay, the most important things that you would want to have checked on before you yourself had surgery. Okay, let's see. Oh, here we go. Okay, so I briefly talked about MH, but let's talk about anaphylaxis and MH. So remember in class I showed you that video, malignant hyperthermia. Sometimes these might look a little similar during the procedure, but only just for slight moments, okay? The important thing is that you understand that they're both catastrophic events, okay? If somebody obviously is having an anaphylaxis reaction or if they're having malignant hyperthermia reaction, okay? They're both life-threatening. Complications may be masked by vitals or some of the anesthesia. Most importantly is we need to make sure we're understanding what's going on with the patient, okay? We're looking at the vitals. Is the heart rate just going through the roof, okay? Are they tachycardic? Or are they bradycardic, okay? Is the temperature going so high that we're starting to worry about MH? What about the end-tidal CO2? Remember, temp and end-tidal CO2 are the biggies with MH, okay? Is the patient having an allergic reaction to latex or maybe some blood products or medications? These are the things that we are worried about, okay? These are the catastrophic events that could possibly happen. So let's talk about MH, okay? So what exactly is it? Well, as I said, it's malignant hyperthermia. And basically, it's a metabolic process of your muscles, okay? And, okay, I just want to make sure I'm saying this right, because sometimes it can be, it's such a horrific occurrence that it's almost difficult to comprehend that this could happen to the human body. So basically, it's a huge increase in how your muscles are reacting to this anesthetic, okay? So you have a patient that has received some sort of anesthesia, okay, general anesthesia. It could be halothane, sevoflurane, desflurane, succinylcholine. You don't need to know those, but those are succinylcholine is the one that typically will cause MH, okay? And really, what is happening is the muscles are just having this severe muscle contracture, and it is causing this immense altered intracellular calcium exchange. So you're having hyperthermia, you're having hypoxemia, lactic acidosis, and you're having anything dealing with cardiac issues, all kinds of cardiac alterations. And basically what is happening is this disease, and so that's what it is. MH is a disease that causes a fast rise in body temperature and severe muscle contractions when your patient receives one of those anesthesia compounds that I just told you about. What is the treatment? The treatment is dantrolene, turning off the anesthetic agents, and providing as much oxygen as you possibly can, and actively cooling, as I said in class. A lot of times they'll put them on ice baths, okay? The best prevention, the most important thing for you to recognize as the nurse is you're making sure that you are keeping the best possible records, obtaining the best possible records while you're in the pre-admission area. Okay, I think that is all I have for you. Hope you have a good day. Thanks. Bye.